So these trainings that we are taught by pairs. So these are just quick assessment areas that you need to learn so that you recognize danger signs in a pediatric patient and immediately intervene. Because these are just things that you'll be doing every day, things that you'll be doing every time you meet the patient. So ABCD assessment and ISBAR is just like should be part of our daily routine in terms of communication. So our learning objective is just to understand the ABCD, E, structure patient assessment, understand the ISBAR communication tool, apply both tools in clinical practice and improve patient safety and communication. So ABCD, when do you do this assessment? So this assessment is done when you see a patient. Every patient that comes to the department, whether in the emergency room, immediately you see the patient, you're supposed to think in your mind, A, B, C, D, E. What am I looking at this patient? Also, sometimes you have to do this assessment in terms of, for example, third floor, we have a patient who is vomiting. So you immediately just go in the room, you look at the patient, oh, his airway is okay, breathing is okay, and then saturation, how is the BP, how is the pulse, how does the patient look, how is the skin color, does the patient have any rash, does the patient have any wounds on the patient, and then just within 5 minutes you would have done the A, B, C, D, E assessment, and then you would have done the conclusion. The doctor comes for rounds, you say, oh, how is the patient in room 3 doing? So you just sum up the patient because you already know what is happening to the patient. Okay? So we are starting with airway. Can anyone tell me how do you assess airway? Any answer? We're just discussing. It's going to be more fun if we are going to interact. How do you assess for airway? How do you know? Yes.
If at all the patient is not having any substance in the nose, or they are not choking, you closely observe if at all, if they are sleeping, if at all their tongue is not rolling backwards. Yes.
Yeah. So airway, the major concern on airway is patterns. We want to make sure that the airway is patterned and the patient is breathing. Okay? So immediately the patient, so remember, when you are doing these assessments, you're supposed to look, you're supposed to listen, and you're supposed to feel. Okay? So immediately the patient comes in, you look at the patient. Oh, how is the patient, the airway, how is it? And then you listen. Sometimes, even when you are close to the patient, you can hear some abnormal sounds on the patient. Okay? Sometimes some people would want to feel if there is air coming from where the patient is breathing. Okay, so you look, you listen, and you feel. Okay, just like our brother is saying, airway, you look at the patterns. Is the patient having any secretions? Okay, is the patient having any foreign body in the mouth, the nose? Is the patient tongue falling backward? How is the position of the patient? Because certain position of the patient, you find the patient is like this, and then the saturations are going down. You don't know what is wrong with the patient. Or sometimes there are some emergencies, like in the emergency room, the patient is coming. And then immediately they come, their position, they are from RTA and the head is like this. So immediately you look at the patient, you see there is no chest rise. Before you even do anything, you look at the patient, oh, there is no chest rise. This patient airway is not parted. You position, the airway is parted. Or there are secretions, you get suction, you suction. Okay? Why is A starting? Because A is very important of the patient. Oxygen is very important in the brain function, the heart function, all the structures in the body. Airway is very important. Okay? So airway, our major concern is what? Is patterns. Okay? Breathing. When you're looking at breathing, you're looking at how is this patient breathing. Okay? Is this patient breathing very fast or too slow? Is it irregular? Are there any added sounds as the patient is breathing? Okay? 2, the other thing on breathing is you look at the leg and how the chest is rising on the patient. Okay? The other thing that you look at breathing is the skin color. So a patient comes, oh, how are you? I'm fine, and how are you? You look at the way they are breathing. Are they having labored breathing? Okay? You look at them. Is there any chest rise on the patient or not? Are there any added sounds on the patient or not? Sometimes the babies come with their mothers or their fathers. They are on the laps. As you're doing the vital signs there, you can be able to see if the patient is having labored breathing or not. Are they using accessory muscles to breathe or not? Sometimes you find the baby. So immediately there, it should signal that this patient has a problem. Okay? And then your assessment starts from there. Oh, airway is parting, the baby is talking. Okay? 2, breathing, the patient is having labored breathing. You look at, you go on with other assessments. So remember, on breathing, we are saying you look at the rate of breathing. Is it too fast? Is it too slow? Are there any added sounds on breathing? Is there chest rise and the chest falling? Is the patient using accessory muscles? And then we have stethoscopes in the emergency room. It's not only for the doctors. Okay? You do your assessment there and then. You suspect that maybe this patient is not having bilateral air entry. Just get a stethoscope and check for breath sounds. Sometimes you can hear clackers. You can suspect the patient has pulmonary edema, especially these patients with CCF, or patient comes with edema in the lower limbs. So you listen to the breath sounds, you can see that, oh, this patient is having clackers. Okay, so these are like quick assessment that can be done. Circulation. So we are moving from airway breathing, circulation. So circulation, we are talking about how is the blood moving in the patient. That's circulation. Eh? What do you assess on circulation? So you check on the pulse, the vital signs. Okay, you check on the pulse. How is the pulse? Is it regular? Is it irregular? Is it fast or too slow? Okay, there's bradycardia and the tachycardia. Okay, so all these things you should have been noting. So by then you look at the patient, you'd have come up with your nursing diagnosis by the end of your what? ABCDE assessment. Okay, circulation, how is the BP? How is the pulse? Okay, how is the temperature of the patient? Okay, the other thing that we sometimes don't do is capillary refill. So you have your watch, you can use the nurse's watch. You look at the patient, compress for 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You see how the capillary is, how blood is coming back to the skin. Okay, this capillary refill can tell us if the patient is dehydrated or not. Okay, the capillary refill can also tell us if the patient is in shock or not. Okay, so you look at the patient. Oh, how is the patient looking? Okay, you feel the patient. How is the extremities? Are they called extremities or not? As you are doing your BP check, how are the vital signs, the pulse, BP, and the capillary refill? So remember, capillary refill, normal capillary refill is less than 2 seconds. If it's above 2 seconds, 3 seconds, it's a very important aspect to inform the doctor. To say, oh, as I was checking on the patient, especially if you're suspecting the patient has been vomiting, because that patient can go into a hypovolemic shock. The BP is low, the pulse is high, and then the capillary refill is also high. Immediately it should tell you that this patient is in what? Is in shock. Okay? So that's on circulation. Okay? Then we go to ABCD, disability. On D is disability. What are you assessing on disability is the neurological function of the patient. Okay, level of consciousness. How is the patient? The patient comes in the emergency room. You check on the airway. Oh, the airway the patient is not breathing well. Okay, breathing. There's bilateral air entry, but there's labored breathing. Okay. Then you go to D. You do your vital signs. After that, you look at the level of consciousness. Is this patient okay or not okay? Is this responding to pain, to voice, or unresponsive? You look at all those aspects. So on disability, there is what we use AVP. AVP. I hope you are going to remember this. So you can use the GSS, Gastroma scale, or you can use AVP. Okay, especially in pediatrics. AVP. A is alert. Is the baby alert? Is the baby responding or not? So this is good for assessment. Immediately the patient comes in the emergency room, you look at, are they alert or not? Okay, even in the ward as we're looking at these patients, sometimes somebody tells you, I think I'm not comfortable with that patient is not looking well. So immediately, if somebody tells you that I'm not comfortable with something, do your assessment. No, this patient is not looking so well. What is your assessment? So that when a doctor comes, you would have told them what you have assessed and what is your recommendation. Okay? So on A, alert, V, voice, is a patient responding to voice. AVPU. Okay, so A, alert, is a patient alert? Or are they responding well? Are they oriented to time, to place? Okay, then voice. If you call their name, hello, are they responding? Okay, then pen. If you pinch, or sometimes you use this on the sternum. Okay, are they responding to pain or not? Okay, and then U is unresponsive. So you do everything. Patient, when patient comes, you check, hello, hi, how are you? How are you doing? So they're not breathing. Oh, you position the patient. They're not, there's no bilateral airway. Yes, can someone give me ambibag? The patient is not breathing. You're doing the ambibag. Oh, somebody is checking. Is the patient responsive? The patient is not responsive. What are you supposed to do when you see a patient who is not responsive? Check for the pulse. Okay? The pulse check, there's no pulse. Start chest compression. That's how quick this ABCD can be done. So if a patient is unresponsive, you look at you, start CPR. No one will come and tell you, no, what you did is wrong. No, you have done your assessment. This is a nursing assessment. You have checked the patient, there is no pulse, the patient is not responsive. Is the pulse there or not? If there is no pulse, start CPR. If there is pulse, concentrate on the airway. If the patient is breathing or not. Okay? Unresponsive, remember, check the pulse. If there is no pulse, start CPR and call for help. Same with the gastrocoma scale, eye opening, movements, and verbal response. Okay, you can do gastrocoma scale or you can do the AVPU. Remember, on D there is also glucose. So every patient comes, you do assessment and responsive or in an emergency, remember to check the what? The glucose level. Sometimes they're just hypoglycemic. That's why they're not responsive. So check the glucose and note it down and you compile your assessment. Then now we come to exposure. Exposure, we are talking about other added things on the patient, like rash, how is the temperature, is the patient having any wounds, is the patient having any other conditions on the patient, on the body, if you do a quick head-to-toe examination. So you check, is the patient having rash? Maybe because of rash, the patient is reacting like this, or because the patient has a wound, is bleeding, because that's why the BP is dropping. So A, B, C, D, E. Exposure, you look at the skin, you look at if the patient has rash, do they have any wounds, are they bleeding? So you look at other factors that could have caused what you have you would have assessed on the patient. Are we all clear? Okay. So that's on A, B, C, D, E. Why am I asking if we're all clear? If there are any questions, ask me. Say, how do I assess for this? How do I assess for this? How do I assess for this? Because I think this is less than 5 minutes I've been talking. And then there's another ISBAR communication, will be another 5 minutes. The next 5 minutes, we'll do scenarios. So someone will come here, I'll tell you what is wrong with the patient. You do your assessment, you tell me what you find on that patient. So I hope we are paying attention that A, B, C, D, E, and what you are looking at in the patient. So you have done your assessment. For example, I'll give you an example of you have done your assessment and your diagnosis, the patient has hypovolemic shock. Okay? So how do you communicate with the doctor that this patient has hypovolemic shock, or this patient is hypotensive, or this patient is, for example, having pulmonary edema, that's why they are not breathing, or this patient has an asthmatic attack, or convulsions secondary to fever. You'd have done the temperature check and you have to say, no, I think I have a patient here who is having convulsions due to fever. So, ISBAR, now, how do you communicate? Identification, very important. You have to, you want me to show you the slides or we are okay like this? We are okay? You are good. Oh. I'll leave this one here so that you, we are here. Okay, yes, here. Okay. So identity, who are you talking to? So identity, whenever you call someone, tell them who you are. Hello, Matron, I'm Emmanuel Rusale. Okay? Am I talking to Matron Gigi? Yes, because sometimes she might be at home, but maybe the maid is the one who has picked up the phone. So now imagine you have an emergency. Oh, Matron, how are you? I'm Emmanuel Rusale. I have a patient here who is vomiting, and I'm thinking if we can put an NG tube. And then the person tells you, oh, no, I'm not the matron. Now you look at the time you have wasted. Okay? So it is very important to identify yourself and also confirm who you are talking to avoid to avoid wasting time, because you're looking at an emergency situation. Okay? So you call, hello, doc, I'm Emmanuel Rusale. Am I talking to Dr. William? Yes, you're talking to Dr. William. Oh, I'm calling for the patient in room 2. Or I'm calling for the patient X, who is age 58 years. Okay? Number 2, situation. What is happening? Right now, why are you calling? That's very important. Why? Because you don't want to bore someone. You don't want to tell them what is not necessary. Okay? I have a patient who has pulmonary edema. Or I have a patient who has hypovolemic shock. I have a patient who has hypotensive, who is hypotensive. That's your situation right now. Okay? Or I have a patient involved in what? In RTA. Okay? Background. Background, you're talking about what is your history for this patient. What have you obtained from the patient? So sometimes the mother will come. No, the child was playing at the ground, and then after playing on the ground, I just found him coming to the house coughing and sneezing and having difficulties in breathing. Okay? Is there any history of asthma in the patient? Oh yes, there's a history of asthma. Or there's no history of asthma. So you'd have gotten the background of the patient on what has happened. So, oh doc, hi, Emmanuel Rusale. Am I talking to Dr. Fu? Yes, you're talking to Dr. Fu. I'm calling on for the patient, a female baby who is age 9 years, who is having an asthmatic attack. On the history, I've obtained that the patient was playing in the ground and suspected that the patient was exposed to what? To an allergen. Okay? What is your assessment? ISBAR. What I'm saying here is, like I'm saying, is in the emergency from there. So, immediately you have an emergency, how do you call and how do you communicate? It's very important. On your assessment, what is your assessment? No, the patient is having labored breathing. Remember what I was saying there? So you don't mention what is normal. Okay? You mention what is what? Abnormal on your what? Assessment. Oh, I have a patient who has what? An asthmatic attack. That's your situation. Background, oh, the patient was exposed at what time, and then they came to the hospital at this time, and they have history of asthma in the family, or the patient is a non-hypertensive patient, the patient is a non-diabetic patient, the patient is a non-asthmatic patient. Okay? And then on your assessment, according to my assessment, the patient is what? Is having labored breathing and also using accessory muscles to breathe. The oxygen saturation is at 86%. The BP is okay. You don't mention the BP is okay, it's okay. So that's your assessment. The patient is having labored breathing, oxygen saturation is at 89. Okay? What is your recommendation? Oh, doc, I'm recommending that we put the patient on what? On oxygen. Or I'm asking if you can come through to do an urgent review. or I'm calling doc, I'm recommending that we put the patient on oxygen, or I'm calling for a quick review on the patient as I put the patient on oxygen. Or you have a patient with chest pain, you have assessed everything, the breathing is okay, situation is okay, the BP is very high, patient is having labored breathing, and then your assessment is that the patient, you are suspecting the patient has an MI or myocardial infarction. So your recommendation will be, doc, we are asking for an urgent medical review on the patient, and also we're asking if we can go ahead and do ECG and chest X-ray as we are waiting for you to come. So the doctor will tell you, oh no, you don't need to do all that. Just put the patient on oxygen, I'm coming shortly. You repeat what the doctor said. Oh, you are saying, I put the patient on oxygen and I wait for you. Yes, okay, thank you. You'd have done a closed loop communication, communicated everything about the patient in a shortest period of time. Identify yourself, situation. What is your current situation? What is happening right now? 2, your background. What is a quick background of the patient? Okay? 3, you talk about your assessment. How is your assessment? And what are you recommending? Okay? No, we are asking doctor if you can come through and review. Or you are trying to treat a patient with the hyperkalemia. We had a patient with hyperkalemia. You give insulin and dextrose. After giving insulin and dextrose, the sugar levels drop to what? To 2. Okay, you've done your assessment. Oh, doc, we have a patient here who is hypoglycemic. The sugar level is at 2. That's your current situation. What is the background? The background is we were treating this patient for what? For hyperkalemia. We gave insulin and glucose. How much did you give? All that you mentioned on the background. Your assessment right now, the patient is having labored breathing, the patient is feeling like vomiting, and we are recommending that we commence 10% dextrose, so we give bolus 50% dextrose, and we're asking for you to come and see the patient. The doctor will tell you, oh, you can go ahead and give what? 50% dextrose, 10 mils or 20 mils, and then I am coming shortly. Then you repeat what the doctor said. Oh, you're saying, I give 10% dextrose, and you said you're coming shortly. Then they say yes. Then you have done your what? Your communication on ISBAR. Are we all fine? Are we okay? Can we do our assessment? Any questions?
So, they are on disability. You said ABP. So the P is what? The P is what?
Pain.
No, it all.
Yeah, that's why I came to it.
Yeah, so the P is pain.
Pain. So is the patient responding to pain? Because you call their name, they are not answering. They are not alert.
So you
Voice, they are not responding. So
you use pain.
you induce pain to see if the patient would what? Will react.
So on disability, so you check how the patient is, how conscious the patient is.
Yes. So you are looking at the brain issues. How is the patient responding? Is the patient okay or not okay? Is the patient awake or not awake? That's what I'm saying.
I was thinking you check maybe if the patient is injured, if they are having any disability.
Exposure.
Yes. Okay. In addition to that, like the disability, especially we are looking at the neural function of the patient. You can find out, we have the position of the patient. How is the position of the patient? How is like the hand movement? How is the leg movement? Patient is not talking, is not responding, but patient is showing even like the cortication, something, the movement of the hands. Okay, that one it involves on those things that you are seeing with the patient.
So like I was saying, you can use GSS. On GSS on motor, you have those gradings, whether the patient is moving toward the pain or away from the pain, or they're just being like this. Okay? So we are good? Yeah. Okay, so understood, we have these papers here as you'll be doing your scenarios. If you want to look at them. So you can pick which page you have not understood. This is ABCDE and what questions to ask and how to ask them. Okay. Yes. So we are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Okay. So we can be 3, 3, and then the other group will be 4. Okay. So here we are group 3. There group 3. Okay, 4. Yes. So here you be 4. Here will be 3. We get special here. Okay. So we start with so we are going to be doing one group at a time. There are just 4 scenarios, So the quicker we do it, the better we finish. But it's supposed to be done accurately. Okay. So you'll be doing your assessment, and then I'll be telling you what you find on the patient. You can have a pen and a paper so that we see how you are going to report. Pen and a paper, you need it. Anyone could just give, because you'll be going to the next group. Like a pen and a paper, like I just want them to be